Dermatology is skin. The best way to learn about dermatology is to go to outpatient clinics or clinics where you can see a lot of conditions very quickly, but that may not be possible in your training. Also, get a skin atlas. You know, there's atlases that show hundreds, if not thousands, of different skin conditions, and flick through this. This is very important to be able to do this. Now, the thing about dermatology is that you as a doctor may not put a lot of importance on it. After all, how many people die from skin conditions? Well, there's about 2 conditions where you can die. But most of the time they're pretty important to the patient because of their appearance, cosmetic reasons, inconvenience, shedding, sometimes a lot of discomfort. So they can be very important to the patient. It's important that you know about it because in a emergency room, clinics, outpatient clinics, general practice, a large percentage of problems, yes, will be orthopedic, but also there'll be a large percentage of problems related to dermatology. So you really need to know something about it. Now take, for example, this first condition that we're talking about. We're talking about acne, teenagers, acne vulgaris. I'm going to go through these talks. I'm not going to go slavishly through every word. You can read it from the video, from the screen. I'm just going to go over and highlight it. It's going to be several videos. So acne vulgaris, that's pretty important, isn't it? Comedones, papules, pustules, nodules, adolescents, diagnosis obvious, topical systemic steroids to reduce the sebum production, course of antibiotics. Sometimes you have to use retinoic acid. Perioral dermatitis, I see that in children around the mouth and may need a course of tetracyclines. Rosacea, acne rosacea, these are the rosy cheeks of the English and the Irish. It's actually a chronic inflammatory condition. Facial flushing, you can read through it here. Adults, it's obvious diagnosis and it will need treatment with some topical medications. Bacterial skin infections, here you see a dramatic skin manifestation of meningococcal septicemia, misspelt there, I'll have to correct it, septicemia. Look at gangrenous extremities. Well, this is a very extreme condition where the patients can actually die and end up with terminal amputations. Another common skin infection, MRSA, pretty dramatic. Bloodstream can get into the bone, into the skin, can be very hard to clear. And here's another dramatic one for you, syphilitic ulcer in HIV patient. So they're very difficult problems to treat. Now, cellulitis, very common actually, acute bacterial infection of the skin, usually group A beta hemolytic strep, Staph aureus, pain, swelling, diagnosed pretty obvious, do cultures, swab, maybe some blood cultures, treatments, antibiotics, and usually settles down, the cellulitis will settle down. Cutaneous abscess, painful swelling, pus in the skin under the surface, quite painful. You can treat it, it's obvious, you may need to excise a minor surgical procedure and the appropriate antibiotics. Erysipelas used to be very common, it's related to strep infection, it's not so common now. Erythrasma, that's an infection, Corynebacterium minutissimum, it's common in diabetics. Diabetics are very prone to a lot of skin infections, by the way. Furuncles, these are large abscess, staph, hair follicles, surrounding tissue. Carbuncles are clusters, diagnosed obvious, painful. Treat local factors, warm compressors, and antibiotics may need drainage. Hidradenitis, young men, these are hygiene issues, chronic inflammatory condition, apocrine glands, you know, the armpits, groin, men not washing themselves, young fellows properly. Impetigo, superficial skin infection, crusting and bullae from strep, staph, or both. Lymphadenitis, acute inflammation, one or more lymph glands. You can feel, this swelling in the armpits, neck, and in the groin. And this usually indicates, does an infection distally, somewhere in the hand, somewhere in the foot or leg, that the glands are swollen, painful. Lymphangiitis, well, that's it, infection along the lymphatic channels, often strep. Now, this is a dramatic condition. Necrotitis, subcutaneous infection, dramatic, life-threatening, aerobic, anaerobic bugs involving the fascia, arms, legs, extreme pain, tissues very hot, swollen, severe cellulitis, patients very ill, diagnosed, history, exam, overwhelming infection. Well, this is pretty big deal. This is one skin condition where the patient may die. Antibiotics, surgical debris, we've got to get the surgeons involved. Prognosis poor unless early aggressive treatment, mortality of 30%. So this is a condition you'd sometimes see. Dramatic, patient unwell. Remember, if patient's unwell, they know it's pretty serious. Got to get your colleagues involved here, the surgeon. Staphylococcus scalded skin syndrome, an acute epidermolysis from staphylococcus toxin, newborn children, symptoms widespread, bull-eye, diagnosis, exam, biopsy, appropriate antibiotics, excellent timely treatment. Remember, staph's always around. Now, benign tumours. So we've gone through infections, now we're talking about benign tumours. There's quite a few actually, but there's also some malignant skin tumours. You've really got to be on the game to pick these up. Now, benign tumours, dermatofibroma, a firm red to brown small papular nodule made of fibroblastic tissue, thighs, legs, epidermal cyst or keratinaceous cyst, sebaceous cysts. These are common actually around the scalp, slow-growing sebaceous cysts, keratin in the scalp, swelling. They look a bit large, can be a size of a air golf ball. Not serious, but patients get rather concerned. Now, keloids. You've got to be aware of keloids, a fibroblastic tissue area of injury, surgical scar. Now, these can be quite distressing to the patients. They have an operation, it's gone well, the scar ends up all heaped up. Keloid. American blacks are particularly prone to it. So treat with intralesional steroids, sometimes excise the scar, but it may recur. But it may settle with time, so don't rush in with surgery. Patients can be quite distressed by these. Keratoacanthoma, firm flesh-coloured nodule, sharply sloping borders. Lipoma. Lipoma is a large swelling of tumour, you can read it here. The benign, of course, and you can see the picture here. See a large lipoma in the shoulder area. Nothing serious actually. Liposarcoma I mentioned here, but it's pretty rare actually. And it'll be larger, it'll be changes to the MRI. So lipomas, benign fat tumours, large, patients annoyed about it, and it become quite stressful. Now, in contrast to lipoma, yes, moles. These are terrible problem, you know. You've got to really be aware of them in Australia, Brazil. These are one of the #1 killers in countries with high sunshine. Pigmented macules, papules, nodules composed of clusters of melanocytes or nevus cells potentially become malignant. Lesions of concern, you've got to know this, changing or highly irregular borders, colour changes, pain, bleeding, ulceration, itching, biopsy or excise. You've got to biopsy or excise this. Now, these are probably outside your area of expertise as a medical student or a junior doctor. But if you notice these changes in a mole, you've got to report them or send them to a clinic, a skin clinic that deals with this, or to a dermatologist. You've got to know the difference between a compound nevus, halo nevus, intradermal nevus, junctional nevus, lentigo. Atypical moles, melanocytic nevo, irregular, ill-defined borders, variegated colours, usually brown, tan, macular, and popular parts. Monitor and biopsy are highly atypical change lesions, reduced sun exposure. Now, worrisome features continue to appear after adolescence, tan to dark brown colours, in other words, goes from tan to dark, fried egg look, flat rim, pigmented blurs at edges and notching, on sun exposure cover areas, 1 to several dozen lesions, no family history. In other words, moles, changing colour, changes in appearance of it, got to be checked out, family history, people who are particularly prone, fair skin, and these have to be dealt with. So it's either a biopsy or excision of the mole, and this is probably best dealt with in a skin clinic or with a specialist in that area. Know or read a little bit more about moles than I've presented here. Seborrheic keratosis, nothing dramatic, warty looking lesions. Skin tags, here's a dramatic one of a neurofibromatosis skin tag. They don't really matter too much. Now, vascular lesions. The vascular lesions, I'm going to cover it in part 2.